breastfeeding in preterm and LBW infants. Some contents of my presentation. Before getting into the contents, let us just recollect the theme of this year's World Breastfeeding Week, that is making difference for working parents. Let us make breastfeeding and work together. So this has been the theme of this year. Now moving on to the presentation. Coming to the introduction, preterm infants have a gestational age below 37 weeks at birth, and low birth weight means weight below 2.5 kg. This everyone knows. And low birth weights could be both preterm as well as IUGR. Now coming to the global estimates of prematurity and LBW, they can range from 15% to 20%. In India, nearly 1/3 of live-born babies are LBW, and that amounts to be 8 million every year. And these people have 11 to 13% increased life risk. Approximately 45% of all children under the age of 5 who die are newborns. That means to say, out of all under 5 deaths, 60 to 80% would be newborn, and they are usually premature and or small for gestation age. Preterm and LBW infants have 2 to 10-fold higher risk of mortality than infants born at term. That is why now the care of LBW or the preterm babies has become a national priority, and India is taking a lot of efforts to manage these children. Now, first among them is a nutritional management in preterm infants that plays a vital role. That's because it is the one which is a cornerstone for the adequate postnatal growth and long-term neurodevelopmental outcome of these children. As we know that the maximum brain growth, the maximum immunity growth, maximum organ growth, everything happens between 32 to 36, 32 to 37, or the till term. The maximum growth of the babies happen. And the babies who are born preterm would miss this particular important stage, which leads to a lot of stores and immunological mediation. So they become vulnerable for many diseases as well as many infections. So, and also if they are not taken care at right time, even the cognitive, the capacity of these children and the developmental capacity would also come down. Now, to manage this, what is the best choice of milk? Invariably, it is mother's own milk, right? If not available, then nowadays the emphasis is on use of pasteurized donor human milk. That is also not available. Only the last but the least choice is the formula milk. Now, moving on to feeding and nutrition of low birth weight babies. As I said, immature organ systems and small gastric capacity make these children more vulnerable. Weak suck reflex and poor suck swallow coordination are there for these preterm babies till 34 weeks of gestation. So they may not be ready to feed directly. Incompetent gastroesophageal reflex, the sphincter, and the poor gag reflex make them vulnerable for aspiration. Then decreased activity of enzymes like especially the lactases, lipases, and decreased bile acid pool. Also decreased activity of other enzymes are responsible for catabolism of other important amino acids like tyrosine and methionine that make these children vulnerable for infections. Low glomerular filtration rate and decreased concentrating capacity of the kidney leads to loss of the nutrients and the electrolytes through the urine. Then postnatally, preterm lose more weight, about 15 to 20% of the birth weight as compared to the term infants. Now coming to feeding and nutrition, knew that upon this, these LBW babies also have smaller metabolic results. As I was telling, 32 to 40 weeks of gestation, maximum of hepatic stores of glycogen and the lipids takes place. And being preterm is what makes them depleted of these things. Greatly increased energy requirements are there for these babies due to high rate of BMR, increased growth potentials, and increased stress and associated metabolic problems like hypoglycemia. Just imagine a baby born at preterm having a weight of 1.5 kg, and it has to double its weight before it has to be independently sent out, or by 5 months it has to double its the expected weight to meet the normal growing children, and triple its weight by 1 year. It's a tremendous growth. So this potential has to be done only with the management of nutrition. Then 90 to 95% of very low birth weight babies, and extremely low birth weight neonates are 10 centile of their weight, length, and head circumference at birth. And the long-term follow-up of poor catch-up growth for these babies are seen at the age of 1 year, which is considered as a critical period for the growth and development. Now, early nutrition plays a very important role for subsequent long-term growth and neurodevelopmental outcome of these babies, especially for those extremely preterm. Now, what can be done? What is the goal of this breastfeeding or the feeding of these LBW? The goal is that to provide to meet the growth rate and the body composition of normal of the same gestation in terms of weight, length, component, including cell number, structure, concentration of nutrients and developmental outcomes. So, in other words, to say, preterms can be classified into 3 categories. Preterm, who are born less than 36 weeks. In them, very preterm means less than 32 weeks, and extremely preterm means born less than 28 weeks of gestation. Late preterms are born 34 to 36 weeks. Nowadays, there is a major chunk of newborns preterm are under the category of 34 to 36 weeks because of the various reasons. Now, IUGR are those who are born after 37 weeks, but they have weight which is less for expected gestation age. Now, these are the common problems associated with the preterm babies, which everyone are very familiar. So, coming to the respiratory problems, hyperbilirubinemia, retinopathy of prematurity, intraventricular hemorrhage, hypoglycemia, like that. So, also many of them are even associated with the low birth weight babies. Now, coming to the nutritional goals of these premature babies, especially very preterm babies, when to start. Now, early enteral feed provides the vital nutrients and promotes necessary growth. It's all known fact. And what to introduce, that is the thing. We know that extremely preterm babies or very preterm babies, they of course at birth needs the NICU care. They may not be ready to take enteral feeds. They might be having associated complications, so they need to be admitted there and to be managed. And I'm not going to touch upon that part for the today's presentation. I would be concentrating more on the enteral feeding aspect. Now, once these babies are stable, they require to be initiated with the early maternal expressed feed, preferably within the first 2 days of life, and they can be slowly advanced to at the rate of 30 ml per kg per day in infants who are greater than equal to 1000 grams. They can be later, along with this, substituted with IV fluids, along with the introduction of parenteral amino acid infusions and lipids also as soon as possible. We all know that previously the guidelines were telling that in the first 2 days, the baby has to be treated with the dextrose alone. But the latest studies have shown that the initial malnutrition which the baby develops because of lack of proteins and fats, the child would be continuously falling behind in the neurodevelopmental outcome. So the latest guidelines say that you have to start even the amino acids or the protein infusion right from the day one. As the days progress, the IV fluid has to be reduced and the baby has to be encouraged to feed breast feeds. Early feed duration of TPN and high dependency care and the lower incidence of cholestatic jaundice and an improved standard deviation score for the weight at discharge are the benefits of initiating the early feed. As soon as the baby is stable, American Academy of Pediatrics recommends initiate feed preferably in the first few days, especially so in the less than 5 days after birth, preferably on the second or the third day, once you are sure that the enteral activity is fine in the preterm baby. Then these small amount of feeds which are initiated are called as trophic feeds. And how much to give and what are the benefits of these trophic feeds? 12 to 24 ml. You can initiate as small as 1 to 2 ml and can lead up to 12 to 24 ml per kg per day, continued for a period of time before advancing to the full feed of volumes along with the parenteral nutrition. Early trophic feeding, therefore, accelerates the gastrointestinal, physiological, endocrinal, and metabolic maturity as well as gut motility. It is shown that babies who are initiated with the mother's own milk for the early trophic feeding, their gastrointestinal bacterial load will be ideal, and that can prevent the possibilities of necrotizing enterocolitis in newborns. They also improve the blood flow, promotion of the colonization of the bacteria, allowing the infants to transit to a full enteral feed quickly. Thus, once the 100 ml per kg feed of breast milk is achieved, then one can start using human milk fortifier to meet the nutrition needs of the baby. As we know, very preterm babies have a nutritional need, caloric need, which is almost double what is that of a term infant. And that cannot be met, even though we say that premature milk has a higher energy, but that cannot meet the needs of the growing child. So that makes it there is an essentiality to fortify the human milk with the HMF. Exclusive human breast milk likely to decrease the hospital-related morbidity also, and less infective episodes, and actually lead to better weight gains in these preterm low birth weight babies. So this is a depiction of the tube feeding. Babies who are greater than 32 weeks of gestation, who are having a birth weight of around 1,500 grams, who have a poor latching and the muscle tone to feed at a direct breastfeed, are initiated with a tube feed. Now, what are the other things that can improve the nutrition of the baby? Along with the oral feeds, kangaroo mother care for preterm babies and low birth weight infants should be started as soon as possible, preferably if possible on the first day of life itself. It has been strongly recommended by WHO, and it says that kangaroo care can initiate a better newborn mother bonding, increases lactogenesis, it increases the activities of the baby faster, and the transition would be better when you initiate with a kangaroo mother care. This associated with the decreased motility of all causes, like the mortality causes for newborns, and reduced sepsis, reduced length of hospital stay, increased lactation as well as weight gain in the baby. Now, coming to mother's own milk is the one which is recommended for feeding of these preterm newborns or the low birth weight babies. including very preterm babies or very low birth weight babies. So mother's own milk is the one which is the rich in antibodies and immune mediators, which can make baby more strong and easy transit to the normal life. When mother's own milk is not available, then only the choice is donor's human milk. Now there is a little, because now all the hospitals may not be having the milk banks. In that condition, it becomes difficult to get the donor human milk. The commercially available donor human milk are very costly affair. So that time, invariably, the preterm formulas can be adopted this. But whatever it is, the best possible thing available for babies to feed is, of course, mother's own milk. Matureva pibetstamim. Now, there are a lot of researches nowadays have been done on mother's own milk, and the one of the study demonstrate that each 10% dose of a the EHM diet increased medical or the surgical instances of necrotizing enterocolitis by about 21%. And each 10% dose of mother's own milk of total enteral feeds decreases the risk of necrotizing enterocolitis by about 17%. The figures are varying, but this is an average, this one. Then more than that, 50% of hospital days can be curtailed by introducing mother's own milk. If only the neck and the sepsis could be prevented, 50% of the hospital day stays could be reduced for the newborns. Now, this is one study which demonstrate the effect of fresh mother's own milk and pasteurized donors human milk. And you can see, look into the figures that says that, so babies who are fed with a mother's fresh milk, they had a better survival rate, reduced neck, and reduced the bronchopulmonary dysplasia, and ROP was also less in these babies, and the nutritional outcomes were, as though it was comparatively better with the calorific value with a fortified donor's milk, but there is no matching for the mother's own milk. Now, coming to there is an increasing evidence that the babies who are fed with a formula milk had a higher episodes of necrotizing enterocolitis and feed intolerance. Then multi-component fortification of the human milk is not routinely recommended for all preterm babies or low birth weight babies, but they may be considered for very preterm babies or very low birth weight babies who are fed with a mother's own milk or donor's milk. That means to say the mother's milk is good enough to meet some of the needs of the baby, but if it is a very preterm or very low birth weight baby, mother's milk is not enough to meet the calorific value. That time it needs to be fortified with a human milk fortifiers. When mother's own milk and donor milk are not available, as I was telling, nutrient-rich energy preterm formula can be used to feed these babies. The babies who are less than 32 weeks or very low birth weight babies less than 1.5 kg, as I was telling, can be adopted with an alternative feeding method like, tube feeding, otherwise called as gastric gavage feeding, by introducing the gastric tube or the orogastric tube or the nasogastric tube. Those who are stable babies with a coordination of sucking and swallowing can be introduced with a cup feeding. And the feed volume can be increased up to 30 ml per kg per day. And the guideline says that the babies has to continue this exclusive breastfeeding for the next 6 months. And this is the kangaroo care. As I was telling, kangaroo care is the one which helps in the early transit, better maternal infant bonding, and better lactogenesis in the babies, especially for these preterm and late preterm babies who are at the risk of developing. Now, babies born between 32 to 34 weeks of gestation can take feeds from small cup and from a spoon or a pallida. Once takes cup feeds well, then one can reduce the tube feeds. Another way to feed a baby at this stage is that one can start with a cup feeds once or twice a day. Like, more of a cluster feedings will be there for these babies. So that means they cling on to the mother's breast. Both the mother and the babies are getting exhausted because of the shortcomings of the neuromotor instability. The baby would not be getting enough feed also. For those babies, one can adopt to feed either alternate with the cup and the breastfeeding, or periods can be divided. Few feeds with the direct breastfeed and few with the cup feed, like that. Then babies about 32 weeks of gestation or more are able to start suckling at the breast. Thus, they may be allowed to breastfeed with the supplemental cup feeds till the effective suckling is achieved. And initially, baby, how do we know that the baby has achieved an effective suckling? Initially, baby would take 4 to 5 sucks and then pauses for up to 4 to 5 minutes. Then the baby would start resucking. Now, it is important to not to take him off the breast during this period. Leave him on the breast so that he can suckle again and he is ready. It is important to offer the cup at the end of every feed because the amount of feed the baby would have sucked would not be able to meet the energy needs of the baby. And one has to ensure for proper suckling, one has to ensure there is a proper positioning and latching. Yesterday we had learned regarding the proper positioning and latching, and one can adopt the same principles here. By about 34 to 36 weeks of gestation, one can take all that they need. The baby can directly take all that they need from the direct breastfeeding. So these are the various methods of feeding low birth weight babies. The first one is cup. Nowadays, the idea of bottle feed is very bad because the baby may later develop a nipple confusion between the bottle and the direct breastfeed. So that leads to the failure of the breastfeed. So the cup feeds are always encouraged. Cup maintains the rationality of holding the mouth open, curling the lower lip, and thrusting of the tongue. Everything is maintained with a cup feed. So one can use the steel cup with the not sharp edges, or one can use this silicone feeding cups are available, which are easy for cleaning and maintaining. This also reduces the incidences of gastrointestinal infections following the bottle feed. The hospital setup, one can try giving the syringe feeds. The pallidi feed is the most one everybody in each home are trained of, and they are very comfortable. Babies are also very comfortable to feed with the pallida. Or else the spoon feeding could also be used for these low birth weight babies. Now moving on to the late preterm babies. Now these late preterm babies are defined as those who are born between 34 to 36 weeks of gestation. They nowadays account for 75% of all the preterm deliveries. And although late preterms and these late preterm babies are apparently well, or it's called as early term or near term babies also. They are apparently well at birth to see, but they are called as great dissemblers. That means they often look like full-term babies, so they are treated as such. Although they have an ineffective mechanism of the neuromotor tone, the degree of immaturity prevails in all these children. So they may be at a higher risk of many clinical problems, and these outcomes are inversely correlated to the gestation age. So now late preterms have twice the risk of neurodevelopmental disability as compared to the term babies. Now, what are the concerns with the late preterm babies? So we know that the preterm babies are diligently cared at NICU. They have every facilities. They are cared at NICU. But these late preterm babies are the one who are mostly neglected. They, as I said, they appear to be term, but they do have weak suction pressure because of the poor muscle tone. So when the mother attempts to feed them, they slip off from the mother's nipple. And they have a very diffuse sleep-wake cycle that makes them difficult to continue the feeds when latched onto the breast. So because they will be frequently falling asleep, and the mother feels that the baby has taken feed, but in fact the babies would not have taken enough feed. Poor coordination with the sucking, swallowing, breathing that can predispose to cardiorespiratory instabilities for these children. As we were discussing previously, they do have low glycogen stores. Then they are prone for hypoglycemia very frequently. And we all know that the brain maximum growth takes place in the last trimester, and they are missing this part of growth of the brain. The brain volume increases exponentially between 34 to 40 weeks. Thus, they will be having some neurodevelopmental risk. So, this is the mechanism, the immature physiology leading to poor sucking and immature suction pressures. And because of the poor sucking, they can even lead to impaired lactogenesis 2 to the mother. As we know that lactogenesis 2 is majoritarily depend upon the stimulation which is given by the baby by sucking at the breast. Maternal causes for, now moving on to, there are some other causes for poor lactation and poor nutrition of these late preterm babies. So they include, per se, prematurity itself is a greatest risk factor. Along with that, these ladies could also be associated with the conditions like gestation diabetes, PIH, then increased maternal BMI, right, cesarean sections, intrapartum complications, and that leading to prolonged bed rest. So all these are the risk factor for the premature deliveries. And as I was telling, the lactogenesis 2 is triggered on the day 2 or 3 in the mother by withdrawal of the steroidal hormone, namely progesterone. Transition to from colostrum to the mature milk, from a few drops till 500, 600 ml, which is needed by the baby. It requires this effective stimulation. But what happens here? So, because of the poor secondary stimulation, and if the baby does not give a proper stimulation at the breast, the number of secretory cells and the density of the prolactin receptors in the mammary epithelial cells will not be effective. That reduces the milk secretion in the mother. Now, there are certain other things which, as I was telling, the baby's suckling and the preterm and late preterm babies cannot produce an effective stimuli. Now, it is also a stage where the lady requires important support from the family, and sometimes lack of family support and poor education on the lactation makes the lady difficult to establish the proper lactation during the first few days of the postnatal period. That makes it difficult for feeding these late preterm infants. Now, coming to the IUGR,